I try to take you through a story which is not about only one project, but it's basically about why we should change. It's about what we need a data-centric architecture, and that's what CumuluZ is trying to provide. Explaining why data shouldn't be locked as beautiful as well in all these systems. Just to get ahead. As I said, CumuluZ is putting health data to work. That's what I'm trying to explain to you. I think I have 20 minutes, so I'll go through some of the slides. This should work with this. Oh, next slide. Next slide. Thank you. Next slide. Why healthcare cannot stay the same? That's what I try to explain to you. We have a number of national healthcare programs where I explain why they don't solve our problems. The healthcare industry is changing, and the role of data with it. I think I don't have to do that a lot because I think Henrik explained this morning exactly as I did in this presentation. CumuluZ puts health data to work, so I explain a little bit what the program is, what the initiative does, and there's also a call for action to all of you to, in the end, to really work together. So next slide, please. Why it cannot stay the same? Yeah, actually, there's a number of things in society and technologies changes which really pushes to change. You cannot say that's accommodate. I'd like to highlight two of them. That's great. That's what I think now. Great. I'd like to highlight a couple of them. I mean, the aging population, the rising costs, the demand for health that rises, and the tight labor market. And one of the things is, if you look at some statistics from a national statistics institute, then you see that we have the baby boom, of course. We have people at 26% of our population is over 65, and they're not all healthy. And what you see here is also that the life expectancy is raising as well. So we have the baby boom and life expectancy which rises, which means that we have a lot of old people in our society. So that means double aging. And these people do not get I mean, they get older, but they don't stay healthy and old. So what you see here is this, the life expectancy in good health is not really increased. So that means we have more people who are ill, which has a high demand of care. And the most costs are made in the last stage of life. So you see there from 70 on, and older people are really getting expensive. So if you really plan to get old, realize that you're really getting an expensive person in society. So what you see here is that the life expectancy has raised now to over 81 years. But you see there as well that in good health, you see that you see here that it's only 65 years, 66 years. So that means there's 14 years that you're really ill. And here there's also a lot of people with chronic diseases because that starts at 45 already. So we have a lot of people which need care. And that has an effect on costs because the most expensive thing that's done for people, and that means that costs are rising. If you look at the prognosis in 2015, you see that it's rising pretty fast, and we're already costing 100 million more. So that means that if we go continue this, we spend over 20% of our gross national product on healthcare costs, and that's not sustainable. I mean, we cannot pay that. So that means that we have to change some things. And this is another aspect which really needs us to change because we have a human resources crisis in healthcare. Currently, there's 1 in 7 people working in healthcare, but if we continue to do it like this, 1 in 4 should be working in healthcare in 2040, and in 2060, with all the old people with mobility and all kind of illnesses, we have 1 in 3 people, and that's not sustainable as well. So we don't have the people. We even don't have them now. So why would we have them? We need even more. So you don't have to be a genius to really understand that it has to change something. And this is what struck me when I prepared this presentation. There's 2 statements of Einstein that I came across, and one of those is insanity. And his definition of insanity is doing the same things over and over again, expecting different results. And that's exactly what we're doing now. We keep on working like we always did, and we know that we're running into a real problem, but we're not changing things. So what answers do we have to an aging population and the tight labor market? And, well, the rising healthcare costs. Actually, if you really want to change it, you have to break it down to 2 things. That's meaning reduce demand for care and raise labor productivity. And I think a lot of the initiatives that we do in healthcare IT currently are not really focusing on this. We create all kinds of new services like e-health, and we can monitor people at home, and we identify illnesses earlier, and it means that they're longer patient, but we make it cheaper or we get more efficient. No, most of the time it's more additional healthcare services that we provide, and we're not really solving the problem. So then we hope our national programs will solve the problem. So that's what we're looking at now. So what are they doing? Currently, we have basically three models. I have to explain that. There are three models to share data in healthcare in general. One model is just what I call healthcare information exchange. You change all kind of health data between systems. You make them interoperable. You create standards to exchange information between information systems. Second model is that you do that, but on top of that, you build a layer which is bringing data outside of the system together in data hubs. And that's what I call the hybrid model, with regional data hubs. And the third model is what I call the scaled Scandinavian model. You see there, sometimes countries who really bring all healthcare providers into one system, like Norway, or we all work in Africa. Then we solve a problem by working in the same system. And in the Netherlands, we are currently using this model. And we invest a lot in that because we have a lot of national programs who invest in promoting interoperability. Basically, what you see here is all these programs which are focusing on what they call better information exchange between healthcare providers and patients. They spent over 469 million over a period of 7 years in these programs. It's an enormous amount of money. And on top of that, also we have some kind of national reference index. It's called LSP, and we already spent over 300 million in that as well. Also information exchange. And we have a lot of money that's spent on kind of clinical innovations. That's done by insurance companies. That's also an amount of 425 million. And they just crumble the money across a lot of projects, which are doing small baby steps, but not really solving the problem. And then we have all kind of innovation research projects, which are also getting money to somewhat improve healthcare while using IT. So, and we've been doing that over 40 years now. So we've been working over 40 years now in promoting healthcare interoperability. And you see all the standards on the left-hand side, and yes, they're still all there. That's one of the problems. And we see all the sectors of healthcare, and some of them exchange pretty well, but some are really detached, so not really connected. So we still have a lot of problems after all these initiatives, which do not really resolve even the interoperability between systems. So if we want to solve that, we cannot do the same. We have to somehow not solve the problems with the same thing as we used to create. So that's our challenge. So I try to somehow look at some of the medical care technology innovations and how we then might be able to resolve that. So we have all these challenges. So we want to do connected care, we want to somehow do teleservices, we want to have telehealth centers, we want to set that up as well. Multidisciplinary consultations, patient engagement, personalized medicine. So all these initiatives, they need some kind of, data layer to really be effective. So in general, that's two ways, bringing data for the patient together. So patient-centric data as in all that kind of initiatives, or you need large amounts of data, cohorts, which you bring together. So population and preventive research health data is what I call it. This is where we're coming from. This is a scattered landscape of all kind of electronic medical records, which are scattered across a lot of systems. This is not an exhaustive list. Some of them, we have like 66 hospitals and 7 university hospitals. We have 5,600 GP practices with their own systems, all of them. We have 120 what I call GP emergency services, houses, we have a lot of mental health institutes and elderly care, and you can do the midwives and the physiotherapists, and etc. So it goes on and on. So it's enormous numbers of different systems. And how do we then connect them to these two data sources? And people will say, oh, the data has to stay at the source, and we do it all federated, and we use standards, and we somehow use registration at the source and promote that they have to use a unified language and standards to do that. And then in the end, the market and IT providers are going to solve our problem. I think it's not really going to work, and that's why probably Erik van Meulen this morning already told you this. We really have to somehow work with the changing role of data. So if we know that healthcare is changing, and we know that healthcare information exchange requires a lot of changes, then we should make a future-proof infrastructure which basically can shift from healthcare information exchange to sharing of data. And this is not a new one, I brought that one to me. So the data silos need to be opened up, and to somehow need to bring that data center together. That's what we try to do in CumuluZ. And actually, this report struck me because it's really underlining what we see in the Netherlands. And the Open Data Group Institute, well, it's a report from, I think, a couple of months ago. And this really struck me. I mean, data registries do not share common data models, and electronic records are fragmented across hospitals and across healthcare providers. That's exactly our problem that we have in the Netherlands right now. And what you see is the way we do that in the Netherlands, because we only exchange and we have a very strict focus on privacy and security. And as soon as data is brought together, we really get, oh, now we get a national health record. That's really not what we want. So we are only mediocre. And if we continue like this, we will probably end somewhere. And then we're just the same as in the COVID crisis, even worse than Bulgaria. So that's not the way to go for it. So that's why we came up with an idea from the, and it's not an idea which is unique, and it's not an idea that we only have within the university hospitals. We somehow try to bring the whole healthcare sector together, but we try to somehow push it in this direction. And that's why we invented CumuluZ. It's an initiative which basically started from this question. All healthcare IT directors said, if you ask the question, where's my health data, it's scattered all over. So we want to shift from the exchanging model to a hybrid model, because we think that in the long distance, that will solve more problems than we currently solve. And if you know that, so what we do in between there, we would basically say we create data hubs. And for healthcare, we would do that based on a data hub with one open common data model, so that we can bring data together, unify data, transform it to the right format, and that can be used to somehow provide the entrance to an API layer that can be used for patient solutions which need a patient-centric longitudinal record. And we can, the secondary use of data can be basically fed from that data hub, so that we can create a platform already that can be used by for research, but also for population management, so more preventive healthcare. And we basically stressed from the university side, there's 3 reasons to do this from our side, from clinician side and from patient side. They really need to have access to all health data that's available, not only to the part that they are in that part of the episode access to, but they want to see it all. We have to somehow ensure that it's sustainable, available outside of the system, so not if we change the system and want to migrate from H61 to 63 that we lose half of our data, so we don't want that. And we have to make sure that, anybody there? And we have to make sure that actually, if you introduce such a thing as a platform, you also need a new business model. And a new business model behind such a healthcare platform is basically that you can wrap all your knowledge, because as university hospitals, we share knowledge. And you can wrap the knowledge in algorithms, in self-management apps that you can really, and services and data services that you can really deploy and share with other healthcare providers. So what we did, we first had this request from the healthcare IT, from the IT directors, all the university hospitals. So we wrote a report, and then we promoted the report to all kind of companies that maybe you should go that direction. And that somehow got some traction, some attention. But and then beginning of this year, we hooked up with the national program for research infrastructure, and we said, hey, if you want the research data, you need to get it somewhere out of this health system. So why don't we collaborate and work together? And we started now to do a proof of concept where we try to prove that data from healthcare systems can be brought in such a data hub infrastructure, and that you can put all kind of ecosystems on top of that. So that's what we're doing right now. So I'll try to explain the high-level solution design of our data hub infrastructure. So it's generic services and integrations, what we already do. You can already say then we put the link to the presentation layer on top of that, but that doesn't always perform. That's what you see now in the north of the Netherlands. So sometimes you need transformation services, so we add them. But sometimes the response is not fast enough, so you need to really bring data truly together, so store it in a data hub. And then you can build algorithms logics around that, and you can open it up by APIs, and to support the data workflows, you can use a workflow engine. And that can be opened up the API interface layer to what I call an app ecosystem. And you also can then secondary use of data for research can be done from that platform, and that's exactly what CumuluZ is going to do. So this is basically the basic high-level infrastructure. And currently, it is really supported to the existing programs which are already running. So basically, we add something to what's already being done, but a step that's missing in our national program. I'll skip this one. Little bit about the proof of concept we currently do. The fire view in the north of the Netherlands, they basically use a build viewer together with Salesforce, and that works for Epic, but it doesn't work for Chipson because they implemented a different workflow and they cannot truly respond to a fire request. We currently do the openEHR Federation. That's what Eric explained this morning. So we try to prove that the multiple instances of OpenAIR can work as a logical whole, so as a whole, and then you can bring data from these different instances in a visual integrated layer, also a file viewer for clinicians, so that they can see, oh, that comes from that source, but you can make trend lines across that to really have a longitudinal record. And third of all, we trying to do what I call the CumuluZ Health Horizon Fire POC, and that's trying to do exactly the same. Then we use Fire for persistence, because currently we only have what we call a clinical summary set, EGZ, which is modeled in Fire. So why would we store it in openEHR if we then have to exchange it in Fire again? So we start, just to speed it up, we start to also store it in Fire and then exchange it. And in that POC, we also transform it to OMO, because that's one of the requests of the health variety community to say we want to somehow already support the COVID use case and try to model it to OMO already. So that's what we're going to do. So we designed together basically an architecture to work together, and this is basically why my call to you. So if we want to bring them back into the driver's seat, our Minister of Health now wrote this letter and said we're going to look at platforms. So this is the momentum. And we really have to build a community here together. So with openEHR, with HL7 and the Netherlands, to look at that future model that I showed you, so a solution target model that we can move in 10 years. We have to work together with the community to build that, to use the right standards, but also in a co-creation of clinicians, IT from healthcare providers and commercial parties to really make this work. And yes, we do need our Ministry of Health, but only for regulatory requirements and legislation to really enforce things to make the standards being used in this mode. So I hope you can work with me on that. I'm really enthusiastic to start with it, so let's go for it. Give some questions.
Yeah, we will take one or two questions. Yes, here we go.
You have to stay there, but
oh,
what specifically do you expect the Ministry of Health to do? And is the new law Vegas the tool?
Yeah, actually, that's a good question from the University Hospital. We already promoted from the start that have a look at what the NHS is doing, have a look at what the US is doing, and please do not really enforce clinicians to use a certain standardized set, and then they have to work with IT providers to really make it happen. Just say to all IT providers, if you want to bring a system to the Dutch market, this is basically the standards that you have to comply with. This is the interface that you have to support, and do it as the US is desired. So that's what I recommend.
You have a follow-up question? Maybe has anybody another question? Because we can take a lot of questions. No, then you can do your follow-up.
Do you expect that without any influence by laws, the industry will make the change?
Yes, I think they will, but that's because I'm an optimistic person. I think if we take the lead from the healthcare provider side and work with the industry and make these models work, then you will get into a situation where everybody says, hey, it works. And yeah, we really have to adapt that as well, because otherwise we're no longer in the game. And that's what you've seen in the Nordics, where they say, oh, well, we had our own system with a proprietary data model, and we want to exchange it, and everybody's doing OpenAIR. So then we should base our systems on OpenAIR, because then we can really work in that whole ecosystem of systems and stay basically in business. So I think it's not the industry who's blocking this only, but we have to somehow push harder from the healthcare provider side and also represent this from the patient side. And then what would help, of course, if the Ministry of Health would support that and not block it. But yeah, in the end, I think we should take the lead. Yeah.
It all depends on the correct requirements the ministry wants from the market.
Yes, but as I said, the requirements can somehow be basically enforced in legislation.
Yeah.
But on the other hand, we should also do that as healthcare providers. If we keep doing what we're currently doing now, it stays as scary as it is. So.
And with that, we're going to end this session.